It is my pleasure to introduce today's speaker and sponsor, the Idaho Health Data Exchange. IHDE is Idaho's statewide health information exchange, dedicated to meeting the needs of healthcare providers and ensuring that Idaho's citizens receive the most effective health services possible. To achieve these goals, IHDE is working with a wide array of stakeholders and actively building a best-in-breed technology infrastructure to provide access to reliable data and information, combining traditional healthcare data with other data sources to help address the medical, behavioral, and social needs that influence the well-being of Idahoans. If you have any questions for today's speakers, please chat them in the WebEx chat feature. To begin, I'm going to pass the presentation over to the Executive Director of IHDE, Hans Kastensmith. Take it away, Hans.
Thanks, John, and thanks for having us on this WebEx. We really, truly appreciate the opportunity to present to our colleagues here in the state of Idaho. So as John said, I'm Hans Kastensmith, and I'm the Executive Director of Idaho Health Data Exchange. And like to pass this along and let my team introduce themselves. It's quite a collection of individuals from a number of the technology companies that are supporting IHDE in our effort to build the best-of-breed technology and bring new services and opportunities to the state of Idaho. Craig, are you on?
Hi, Hans. Yes, I am on. Hello, folks. My name is Craig Jones. I'm the Chief Medical Officer for the Idaho Health Data Exchange and look forward to the discussion.
And Laura?
Hi, everyone. This is Laura Nixon. I'm the Product Manager at Idaho Health Data Exchange through Brilliant. Brilliant is a healthcare IT consulting company that helps Medicaid agencies, HIEs, and federal partners plan, fund, and execute HIE initiatives from beginning to end. My background is in healthcare IT consulting, specifically focused on technology to advance value-based care initiatives and to improve population health outcomes. I lead a twice-monthly national learning collaborative surrounding social needs and social determinants of health, and I'm a member of the Gravity Project Technical Advisory Committee. Thank you for having me today.
Thanks, Laura. Dapper?
Testing, 1, 2, 3, testing.
Wonderful. Thanks, Hans. Yes, my name is Jaffer Traish, and I'm the Chief Operating Officer at Bertha, a public benefit organization. Over the last 24 years, I've worked in state health and human services. I've worked across EHR implementations and healthcare. And then the last several years, a big focus on social care and how to help support social determinants of health and social determinants of education and many other social needs across this country. So thrilled for the opportunity to share here today. Thank you.
Thanks, and Greg?
Thank you, Hans. This is Greg Kripp. I'm ProMedica's president and delighted to be here with such a great group of colleagues. And for Medica, we're 22 years old this year. Our focus is clinical interoperability, data exchange, and data quality with our master patient index. Delighted to be here, and thank you for joining us.
And last but not least, Renee.
Hi, thanks so much. Renee Town. I'm the Director of Quality Programs at KPI Ninja. KPI Ninja is a healthcare technology primarily focused on data analytics. We support HIEs and their many stakeholders across the ecosystem to address the growing data needs related to population health and value-based care. So very excited to be here and give you a glimpse of the enterprise-wide analytics we're providing through this partnership.
Thanks, Renee. And Laura, if you wouldn't mind moving to the next slide. So I wanted to introduce IHDE's new approach towards growing into a more robust system in support of value-based care for Idaho. We really launched on a program to redesign the HIE into a modern health information exchange. We've worked over the last several months since our team joined IHDE back in October to establish a more robust longitudinal medical record that, while in the past we've only really included clinical data, now we're moving to include behavioral health, social determinants of health, health and welfare data, homeless data, substance abuse, corrections, and claims to make a more robust set of information available to the systems that we're bringing to bear here, the services we're offering, and to be able to help our practitioners across the state health service organizations to be able to have a lot more information at their fingertips about what's happening with their patient base in Idaho. We're establishing, or have established, and we'll be launching fully in September 30th, a shared technology services stack that's made up of a new enterprise master patient index, and Greg will be talking a little bit more about that in Formedica, a new enterprise data warehouse, which is fully designed around the FHIR standards, and we'll talk a little bit more about that. We've enhanced our clinical portal. It was the best presentation of data in the world, and there were some, things about it that really needed some improvement. So we've worked hard on making sure that is a lot more usable. We're offering now telehealth, a free telehealth solution, and telemonitoring services to our providers. A new alerts and notification system in conjunction with UHIN in Utah to be able to help service our clients and those patients that go back and forth between our two states. A social needs assessment and referral tool in Bertha, which we'll be talking about, and advanced analytics enterprise analytics platform in KPI Ninja. All of this is really established to support a learning health network within the state of Idaho, especially as the state moves closer and closer to value-based care, more value-based care and less fee-for-service. So we're aiming to support improved outcomes, drive down the total cost of care, do health service area profiling, advance practice and patient dashboards, and do quality reporting. And we'll get into a lot more of what we're shooting for on that with our new stack. So go ahead, Laura, you can advance. Craig, do you want to talk about our sustainability roadmap here just for a sec?
Sure, thanks, Hans. As Hans mentioned, we joined this effort back in October, and the goal was really to look at IHDE status, understand it, and begin to build relationships with stakeholders around the state of Idaho, understand the needs, where they were going, and then take IHDE to a new phase where it's ready to be a state-of-the-art type of health information infrastructure. And so you can see it broken out here simply. That planning phase is when we first started in October, and I would say that went through maybe what we call, or to the implementation phase in March. And that funding, just so everybody can understand, the funding that is helping us do this in March. And that came from a federal initiative called the Support Act. The Support Act is intended to invest in health information infrastructure that makes prescription drug monitoring data more available and helps to address the opioid risk issues. So Idaho was awarded that money in March and then went through a phase of Idaho's legislature deciding and approving whether that money could be used. We started implementation in parallel with that in March, and that funding ends September 30th, a rapid phase to use that money to stand up a new infrastructure, and that's what you're going to hear about today is what that infrastructure looks like. But I'd really like to emphasize what happens from October forward. We're going to have these new capabilities, the ability to provide more complete longitudinal records, to integrate multiple data types, to provide that data back to users in several ways, whether it's through a portal or into a electronic health record, or through an analytics and reporting platform, or extracts for your platforms, or social determinants and population health platforms. It's going to be a number of ways in which that data can be more useful for Idaho and Idaho stakeholders. And we really want to emphasize how we're looking at that last stage, the adoption and sustainability, as an essential piece. We want to continue and broaden actually the work with stakeholders around the state, see how best to make that data available and useful for you, and build the use of it, as Hans said, so that there's a real support in place for value-based models, population health initiatives, and ultimately a learning network that continuously improves. So that's what's behind the roadmap, and then I'll turn it back to Hans and the team so they can tell you where we are in this implementation stage.
Thanks, Craig. So Laura, do you want to present the technology stack?
Absolutely. Absolutely. All right. So when IHDE was beginning its sustainability journey, we knew that we needed to find a technology partner that essentially embodied the same ideals that we did: accountability, transparency, innovation, and agility. It was our goal to harness innovative technology in order to advance the ability to collect, leverage, and normalize data to inform value-based care and population health initiatives. So to walk you through the data flow lifecycle, let's think of our different data sources as streams. So we start the journey of the data coming through our interface engine. That's called Rhapsody. It flows into our new ForMedica Enterprise Master Patient Index. And at this point, patient identity is established, and that's when data integration really begins. The streams of data can now go into other parts of the technology stack, such as Bertha, the KPI Ninja universe, and also our new enterprise data lake on FHIR. And finally, it will flow into the Orion Clinical Health Portal. So by bringing in these different data sources, conventional and non-conventional, to our enterprise data lake on FHIR, we're able to normalize and harmonize this data to be used for advanced enterprise analytics, which would be able to support value-based reporting for programs such as HIDES, ECQMs, the Quality Payment Program, and many others, as well as being used to improve population health outcomes overall. So this normalized data can be displayed on the clinical portal to enhance the patient's longitudinal health record, and it also can be sent to participant EMRs if they have a bidirectional interface with us. So we have listed here on this slide the users that we see on a monthly basis using our technology stack. And, we can see that there's 49 of them that have bidirectional. So this information now with the super stack is able to flow freely between our stack and 49 different participants' EMRs seamlessly. So at this point, I'm going to hand this off to Greg. He's going to talk about the first piece of our technology stack that really starts the whole process. So, Greg, take it.
Thank you, Laura. Thank you very much. So when we started, working with Hans and team and looking at data quality, one of the things that we focus on as a company before we actually bring in a new MPI or replace an MPI, we always want to start and understand where we are with current duplication rate and some of the other data quality issues that are coming in from these various data streams, as Laura profiled. So we did that exercise first, and we were able to help identify areas for improvement, both around the identification and the duplication rate, as well as other areas around registration issues. And that's important to understand that, because putting in an EMPI, and especially when you're doing analytics and reporting and profiling for community care purposes, you want to make sure that you have the right patient identification going with the right clinical information. So what we did was start that review process. We've been through that now. And we've actually helped IHDE get their duplication rate down close to 1%. We're just barely over 1%, but we started off closer to a double-digit duplication rate. So that process has moved very nicely and quickly. What we now want to do, now that we've got our data set clean and we know it's going to be used throughout these various connected systems, it's our focus and responsibility to make sure that every patient in the state or connected regions is represented only once. So that's our main focus. And we know there's always constant demographic identification changes from the various systems that are connected. So we work closely to make sure the data is well organized. I like the term Laura used, data harmonization. Make sure that it's well represented. We can also improve attributes on the data. So if we see that there's missing information, it's the right time to be able to collect the incremental information that really helps organize it and also keep it streamlined. So for example, if there's historical information that's missing, somebody's had a name change, they've had multiple addresses, we like that historical information to come through because we can actually, through the MPI, match and score on that and be able to keep that information in sync. If for some contributing system, they haven't updated their record yet, maybe it's coming in from a hospital system or from a practice, and it's the older information, as long as we have both old and new, we can always match against that. And then we can help organize it, clean it up, and maintain the most current information from the matching process. What that does for IHDE, it allows them now to be much more of a trusted data source on all the state identities, makes it much more efficient and accurate as that's being passed over, through KPI Ninja Universe for reporting and analytics, and ultimately over to Bertha. And so as we're studying and providing value from a connected care community, it really is the beginning step that we need to make sure is always in place. So with Hans and team, as they know, and we've demonstrated over the last several months, we're fully committed to keep, maintaining that data quality. We do guarantee that we keep it at a 1% or less. We actually strive for less than 1% duplication rate, but unfortunately in data streams that come through, we're not always in control of missing attributes. And unfortunately, without certain attributes, it's really hard to make that identification call. So we have to work with the contributing data sources and making sure that we fill in what's missing. We actually are providing IHDE the single source solution, where we're providing not only the eMPI software as the technology, but our people, our data stewards and processes are actually combined in a service approach to actually help them achieve and maintain the duplication rate that we have talked about and that we achieve at the 1% level. And we do this in real time. That's important to understand, because when you're talking about clinical interoperability and various data streams feeding into the HIE, you have to be able to match current information and do that real time. So we're a real-time transactional system. We do assign a unique patient ID to every unique identified source. Then that can be matched, and that can be against unlimited data sources as they come in. And that's across disparate health systems, provider offices, and other connected community care health organizations, whether it's SNFs or mental health facilities, laboratory values, et cetera. So our goal, in this whole ecosystem as the super stack, I love that name, is really to provide data integrity, data management, quality, so everything downstream. And I'll hand it back over to Laura, talk about how the data is used in the next step.
I'm actually going to pass this back to Hans and let him talk about our really great FHIR-enabled enterprise data.
So, we took a look at the different applications or the different types of data lakes and data databases that were out there. Old ones like SQL and some of the newer ones that have JSON strings. And our team has had a lot of experience with data aggregation and dissemination over time. And with the JSON string lakes, we found that our data was locked up too tightly and it was not as available as you would like it to be as in a relational database. And so we decided to go down the road and actually, what would be the point of going backwards or using old technology when we're designing something for the future? And so our engineers took a look at the FHIR-based elements, and while there was some challenges to making them relational in a really well-designed way, they found ways to be able to work with that and fix some of the problems with it. So we've established, I think, an extremely innovative data repository that can handle all the different types of data. It's secure, extremely flexible. New FHIR-based objects can be added at any time to accept different types of data. And then the data lake can be respun up within a couple of days to include those objects to be able to allow us the flexibility of bringing in different types of data. It's extremely economical. It costs about 2/3 less to maintain this than a standard database or JSON string lake, and it's extremely resilient. So, we're looking forward instead of backwards and having the ability to deal with FHIR as it gets more and more prominent in our industry. So, you can go to the next slide, Laura. And
awesome, great.
I'm sorry.
Yeah, no worries. Excited to provide the individuals on the call a glimpse of the enterprise analytics that we're offering. So, at a high level, we support HIEs and their stakeholders with this transition to population health and value-based care. And so while the other participants have highlighted different capabilities, I thought this would be a great opportunity to say, what do we bring to the table and how does that integrate? Because what IHDE has going here with the partnerships is very unique and something you will not find anywhere else in the country. So very excited to be part of this partnership. As a technology and an analytics company, we're extremely passionate about improving health outcomes. So we do not see ourselves as just providing data or dashboards, but rather that information to be a catalyst to healthcare improvement. Because we support HIEs and their stakeholders, we have the technology and the capabilities to support that complex data environment within, like Hans and team have mentioned, with that data lake. So we provide this dynamic, flexible solution that has agnostic data ingestion and outbound capabilities, ultimately creating a single solution for all of the analytic needs. So what does that look like? That's reporting, performance monitoring, care management, and more sophisticated analytics with risk stratification and predictive analytics. We do have built in the established and very proven Johns Hopkins ACG system as well. So we are the only vendor to hold the 4 NCQA seals you see here on this screen, which demonstrates our ability to help IHDE create value in the different healthcare sectors, but also to create this data infrastructure that is so critical for enabling value-based care at scale. So what does this really all mean for you? The HIE, they touch nearly every stakeholder, and we've worked deeply in our experience with different stakeholders and their nuanced data needs and use cases. But at a high level, we see these broad themes that are all related to reducing the data barriers related to not being able to see that right story in an efficient manner. So I wanted to share with you a few examples of potentially what this looks like with this partnership and what you may not be able to do today, but could potentially in the future. One of the best things that IHDE and HIEs bring to the industry is this comprehensive data, the longitudinal patient record. When you build analytics on a single data source, like an EHR or only a few, inherently you're not capturing all of the patient activity and medical history. So the analytics are limited. When you have analytics that are built on top of an HIE and the data lake, as we discussed here today, it helps you fill those gaps that exist within your own internal data systems. One of the other really beneficial things that HIEs bring to the forefront is the benefit of this real-time clinical data. It seems so often quality and population health is managed in a backwards looking fashion, right? Lagging claims data. IHDE brings us real-time information to help you understand performance in real time and alter the outcome, ultimately becoming more efficient at change efforts and accelerating goal achievement through creating this culture, right? This data-driven improvement culture to drive not only outcomes today, but sustainability over time. So I'd like to conclude here just quickly with identifying, like I said, the unique partnerships here are something you won't find elsewhere. And so as Greg mentioned earlier, two things I want to highlight is the capability of providing analytics that are built on a robust EMPI system like Formedica. It allows this valid representations of patients and populations at every level, from the patient, the provider, the organization, to the payer. Absolutely critical foundation to providing accurate and useful analytics that decisions can be made upon. We also know that healthcare no longer lives inside four walls, right? Within the four walls of your provider office or your healthcare system. And so with that, with our agnostic data ingestion outbound capabilities, we have this ability to double down on our interoperability capabilities to provide insights that go beyond traditional medical or health data. Here in a moment, I'm going to hand it off to Jaffer, but looking at analytics from the perspective of social determinants of health, food, housing, transit, and how that compares to their medical data, ultimately to get this really comprehensive understanding of your population and where your service delivery should be oriented. Jaffer, I know you're going to speak more to this, so this may be a good time to hand it off to you.
Certainly, sounds good. So at Aunt Bertha, our mission is to connect all people in need to the programs that serve them with dignity and ease. And this partnership not only supports that mission, but it also brings the network of programs to nonprofits across the state as well, who can then navigate for people in need to programs not only within the state, but also nationwide. And so with millions of users already on the network, we're able to onboard nonprofit locations with trust and collaboration as part of that process. And so what we are showing here is just a heat map of where we're seeing search activity take place. And it's certainly across the country, across the Aunt Bertha network. It's grown quite rapidly over the last few years to millions of users. And that includes enterprise systems, payers and plans and healthcare. It also includes education and corrections, and then certainly nonprofits, and then individual seekers or people in need searching on their own behalf as well. You can advance. Also important, or another benefit of the platform collaboration, is the closed loop referral aspect. And this is very attractive in the healthcare industry, where people in need can receive the dignity of a yes or a no when they're looking for services. And in addition to that dignity of a response, they may be able to receive specific service outcomes that are documented as well. And so in some cases, our customers or the health plans or health care want that service outcome closed loop data to come back into their native system. And that native system could be an HIE, it could be other data warehouses and so forth. And so what this is showing is, while it's sobering that there are more than 35,000 referrals a month happening across the network now, this also means that people are getting connected to the help they need and to the services they need. So we're really excited about this opportunity and the scalable approach that's being taken in the partnership. You can advance. And last but not least, as the theme is ringing here, value-based care and population health initiatives oftentimes see organizations bringing typically cost, claims, chronic disease, and other clinical data together. And I think what's interesting is, with this super stack, this will be a premier opportunity to bring social care risk and needs data into the population health analysis. And so in this example here, one of our own data scientists took a look at the public data for diabetes, obesity, and days of poor health, and for the first time married nationwide data around availability of food and searches for food by county, creating an essential food index that tells us where counties have the greatest opportunity to provide greater resources to increase healthy days by 10% or more. And so we're really thrilled that this super stack is creating the opportunity to take this to the next level and start to scale this approach of population health analysis that includes social care information. So again, thanks so much for having us, be a part of this. And Laura, I'll hand it back to you.
Jaffer, thanks. One thing I wanted to mention before Laura moves on to some of the other technologies, that we did do a press release with Aunt Bertha here a couple of days ago, and it's actually gotten some relatively interesting national attention, where Healthcare IT News and another magazine or another eMag in our industry picked it up and actually are taking that press release and writing articles around it. So I think that what we're doing here in Idaho is definitely stirring some interest in and around the country about relating social determinants of health and having it presented by an HIE, and then backing it up with all the rest of the things that we're doing. And so we're just kind of a little plug. We're pretty happy about that with the response we're getting. Go ahead, Laura.
All right, thanks. So we have some additional components that power our super stack as well. Some of those being some enhancements that we just recently did to our Orion clinical portal. This was based on stakeholder feedback that we were able to glean by holding some in-depth sessions over the course of the last several months. So that's been enhanced as far as the user interface as well as data presentation. Further, we've partnered with a telehealth company that provides a HIPAA-compliant and completely free telehealth platform to all of our participants. We are very excited to partner with MyHilo on this. They have been a wonderful partner, and we're very excited that they've come on board. To piggyback on that, we've also partnered with Connect America. They are a 30-plus-year-old remote patient monitoring device company. They have a number of RPM devices, including personal emergency response for ambulance dispatch, a very comprehensive medication management system, blood pressure measurement, as well as diabetes support. So we're very excited to partner with them, and we have established a bidirectional interface with Connect America so that the vitals information from those devices is able to also populate our longitudinal patient health record history as well. Further, our final partner that we're going to discuss today is Curious Innovations, powered by Health InfoNet up in Maine. We have partnered with them to implement an advanced terminology service that actually allows us to do that harmonization of the conventional and non-conventional data and normalize it so that it can be used throughout all of these different components of our super stack. So that's the components of the super stack. And at this point, I'm going to turn it over to Dr. Jones to talk about the learning health system that this super stack is able to power. So Craig, take it away, my friend.
Thanks, Lauren. You can just go ahead to the next slide. I think the real message here, and we really want to move this into more of a discussion section with you, is the foundation that's being built. And the idea and the architecture behind this really was to move towards a foundation that can help with population health initiatives, value-based care, and really help Idaho's providers and payers and other stakeholders, including community-based organizations, to begin to function together in a new way. And so that's the goal. And what we want to find out and talk to you about is how this may be of value, what you see as the opportunities, the challenges, and your feedback, frankly, if possible, on what you think needs to be a priority. We think that these components that have been brought together really do establish this foundation. And again, as I pointed out, I think it's for multiple stakeholders, including providers, payers, and community-based organizations. In the end, as Renee said earlier, at the heart of this is a more complete longitudinal record involving multiple data types, not only clinical data, but the social needs data, as well as public health data and potentially other data types that we're working on. If payers become involved, it could include claims data as well, which is valuable for certain types of measurement and contributing to certain types of planning and operational needs. In the end, each of these groups will have more complete data to work with, whether it's delivering care for individuals or whether it's the ability to drill down from an analytic result on a diabetes or a COPD population and then look at the panel in that very same platform 1 or 2 clicks away, understand their care needs, and work within your practice to direct better care and coordinated services for them. Or whether it's the ability to find the patients with complex needs in your practice, address their social determinants needs as well as their medical needs, and right there at the point of contact, coordinate services for them for both those aspects. Everybody can benefit from the more complete data in terms of the analytics and insights that it can get for quality initiatives, understanding performance and monitoring. If you think about payers, which is a group that we often don't talk about in these forums, but they frankly have tremendous data needs for their quality reporting requirements, for planning their business operations, for understanding how their value-based initiatives are progressing. And so there's a real opportunity for them to take advantage of and use this more complete data to help with their operations, and it's an administrative it's a burden, it's a reduction in administrative burden for them if they can access this type of information. And then lastly, I want to point to the community-based organizations, and we all know the long-standing need for integration of services between healthcare providers and community-based organizations. And for me, one of the most important things about this stack is the ability to make that happen in real time, to make it actionable. Not only are you asking questions and doing assessments, but you're getting a result and you're able to coordinate a closed-loop referral right there. And then on the back end, that very same data is able to be used to monitor and to understand and to improve performance. So there's a real foundation. That's the objective here. As mentioned earlier, the exciting part is the first phases of all these things that you have been presented will be at some level of operation by September 30th and able to be used by IHDE's participants and hopefully to begin to have an impact. But most importantly is going forward from that point, how we're going to continue to improve this foundation, how we're going to get adoption and use of it and help to support adoption with different groups around the state, different provider groups, large and small, independent practices, rural settings, and how we can really help data take on a new activity in the state. And again, the ultimate goal is this learning system approach where there's actionable information and we're continuously improving. And so that's the opportunity offered and the vision behind this stack. And I'd like to close this section out, and while we have a few minutes left here, open it up to discussion with the group. And ideally, I understand we're using a chat function here, but it would be great to hear from some of the participants about how they view what's being presented, your initial responses, how this may be helpful as you move toward value-based models, and maybe most importantly, what you think we need to address in the functions, what we need to make sure happens in order for this to meet your needs across the state. So with that, let me close it out and turn it back over to everybody so that we can have a little bit of an interactive session.
Thank you for that. If you do have a question, please unmute yourself or enter the question in the chat box.
And And while we're waiting for the chat. Oh, go ahead. Was there someone there? Well, while we're waiting, maybe it would be great to hear from, particularly if there's any providers from smaller practices, independent or rural practices, to start out. And you know, it's often hard to take advantage of data systems. Limited in staff. It's challenging, and we'd love to hear about what kind of support you may need from IHDE, whether that supports assistance with using the information, accessing it. We'd love to hear maybe some feedback on what kind of support services you could benefit from during that adoption phase. Anybody on who can give us some feedback on that?
Yeah, hi, this is Thad with XBO Health. Can you hear me okay?
We can.
Yes.
While we're not a small provider, we're working with the Idaho HIE on engagement with small providers. We have spoken with a lot of those providers. So, at the risk of speaking on their behalf, I would say one of the things that we're finding is that from a technical support standpoint, I think a lot of the smaller agencies, their EHRs and their vendors themselves don't always have the capacity or the capability to provide HL7 type of interfaces directly with the exchange. And so I think that what would benefit a lot of those smaller providers is some technical support services and constructs, which I think, the HIE is doing a great job of providing several ways to engage with the HIE. But I think understanding that a lot of those providers, their systems are lagging behind the great innovations that the HIE has put into place. And so we need some more basic, if you will, ways to get the tech support and the connections they need. So I would just offer that as some of our observations about the smaller providers, especially in the behavioral healthcare marketplace.
That's very helpful, and one of the things that we want to do, and we'd love more feedback from you on structuring this, is to have ready a group of facilitators, if you will, that can work with practices and can help not only organize maybe the right types of connections, even if they're non-conventional connections, but also ways in which the data can be most useful for those practices. There's a lot of levels that can come into play in practice facilitation, and that really is a fundamental part of a learning health system network. And so we will want that feedback in organizing that. We have a team that's really going to be focused on that stakeholder work and practice supports and practice facilitation. And the other thing I may mention along those lines is a data quality approach. You heard a couple things in this about data quality, starting with identity and identity management from Informatica, but also part of the warehouse structure is going to be the ability to quantify the types of information coming in from sources, so we can work back with practices and others to help improve data completeness, because that makes it most useful for everything, including measurement. So we're going to try and take a fuller approach to practice supports as you're describing, and our team with Prudence Vincent and Allison Steinbacher are helping to organize that stakeholder team, and we have some partners that we'd like to work with, like yourselves, like Expio, Co-Imagine, and others on this kind of practice support. So thank you for the feedback, and we look forward to getting down into the details with you all as that goes forward.
Sure. Yeah, thank you so much for the great presentation as well.
This is Hans. Jaffer, I wonder if you could expand a little bit on the closed loop referral capabilities of Aunt Bertha and how that helps practices actually, take care of their patients and get them to the services they need. Do you mind doing that?
Yeah, absolutely. And so as part of joining the Aunt Bertha network, every practice, every organization under this partnership will then have access to a full assessment, search, and referral-based platform. And what that will support is a way to navigate on behalf of people in need by connecting them to programs where the programs have already provided the best connection method. And so one of the benefits here is if there are 2,000 programs across the state, some of those prefer that you schedule into their service, for example, an immigration legal service. Others might require that you actually send them an email referral. Others may require that you complete a screener that asks you if you own your own home before they will be permitted to come to a home modification, like add a wheelchair ramp. And so part of the benefit of the network for the practices and partners is that all that homework has already been done. It's a part of the network. It's a part of what you see when you find a good program. And in addition, there's patient or member context in that search process. And so perhaps you're navigating on behalf of a veteran, or perhaps you're navigating on behalf of a senior that's looking for meetups or senior centers. You have the ability to select those different filters based on who you're navigating for and tailor the network for your search experience to find just those programs that your patient might be eligible for. And I think after that referral or that appointment or that message goes over to the nonprofit, they have free tools now and no forced contracts to participate in that ecosystem. And so they're able to receive that referral. They're able to see what organization sent them that referral on behalf of a patient, and they can follow up with that patient with the best contact method that that patient chose. And that could be phone or email or other mechanisms as well. And so by responding to that referral, they can reply right in that email. They can reply in the system. They can even document additional outcomes like what service they provided in the platform. And that data in closed loop fashion goes back to that source system, this partnership, where that data can then be married to other clinical information or other data that's been consumed. And so while it's one network and one channel, it applies flexibility within that network to both the nonprofits and the seekers who can self-navigate as well.
Thank you for that, Jaffer. There are a few questions that have trickled in. One is, how is patient attribution managed?
Hey, Hans, this is Renee. Do you want me to field that one?
Yeah, that'd be great. You and maybe pass it off to Greg for him to talk to. Thanks for that.
Sure, go ahead and start, Renee.
Okay, great. Yeah, patient attribution, absolutely a critical and foundation component to creating actionable and insightful analytics, right? Putting the information in the hands of clinicians needs to accurately represent their panel, their population. And so again, because we support HIEs and multiple stakeholders, we are very familiar with a variety of attribution models because we know that one model and one methodology doesn't work for everyone, right? So we're dynamic and flexible to the needs. To be a little more specific, to give you some examples, you know, for payers and risk-bearing organizations like ACOs and clinically integrated networks, many times they have their own rosters or eligibility files. We ingest those on a regular basis and assure that the individuals from those organizations, when they log in, those are the patients they are seeing within the application, the dashboards, the reports, and so forth. While that's a great method, that's not always applicable or usable in other settings. You know, many other times it's based on a set of criteria. I know earlier one caller had talked about smaller provider practices. You know, we've heard that some of these settings, they have a difficult time understanding who is their active patient population. So based on their needs and wants, we've created an example is attribution that's based on a criteria like any patient that they have seen in the last 24 months falls into their active patient list. Again, a great methodology doesn't work for hospitals. Hospitals are typically more oriented around encounters, but nonetheless, a critical component, and we're flexible to the needs to assure we're providing the right information. I think it'd be great to quickly pause and give Greg the opportunity to describe the patient matching and the patient identity portion of the attribution.
Yeah, thanks, Renee. So the key part, as we're talking about disparate, data feeds, whether they're coming in from a hospital, a provider, or other community type care settings, it's critical to maintain the medical record number or ID. And in the patient matching environment, you could have a patient who coexists in multiple systems. So it's very important not only creating a unique patient ID that's common across the systems, but retaining those different medical record numbers or IDs that come out of the system. So we do that with no limitation on the number of IDs that can be stored on a patient identity. So there's multiple lab values, multiple CCDs, multiple clinical transactions. Those come in, we match first against the MPI, we validate the identity, we ensure we have the correct patient, and then of course we can now aggregate that information. And as the providers associated with each identity is matched as well, I think that's the key part here. Then you can really create that longitudinal view of all information on Renee or Greg or Hans based on first matching, validating, pulling all the information that's associated with each identity, and then be able to present it out to analytics and share that information.
Thank you, Greg and Renee. I think we have time for one last question, maybe two. What data sources are used to power the analytics?
Go ahead. Whoever was one of our team can answer that.
I'll start that off real quickly and then turn it over to Renee maybe to talk a little bit about but there are several data sources that we're working on that can help our team. One is the clinical data that we receive from feeds from providers and EHR systems, and you heard a lot about the approach we're taking to try and standardize that data and make it more usable, including the identity management aspects of it. Another source of data is directly the Aunt Bertha social determinants and social needs platform. That data is going to be extracted from the Aunt Bertha platform and put into the warehouse, where it can be ultimately linked with the clinical data, again, setting in place a more complete longitudinal record. We're working on incorporating certain public health data. We've been able to provide access to a view of vaccine data in the portal, but not yet receive the vaccine data. We'd like to work with the Department of Health on a couple different data sources that could be very beneficial at helping to establish a more complete record. We've been in discussions with the Department of Corrections about data from that department. Becomes very important in programs that are addressing things like risk from opiate misuse and addiction services. And then ultimately, we're beginning to talk with payers about maybe opportunities for incorporating claims data as well. And claims data can be a very powerful piece to a longitudinal record for understanding care patterns, gaps in care, performance related to quality and utilization. And so that would be another piece. And the key being able to, the ability to establish the identity across those different data sources, standardize that data as much as possible, and establish the ability to link it for various analytics and as well as care management and population health initiatives. But let me stop there and turn it over and see if Renee or others have more they'd like to add on.
Yeah, great. Thanks so much, Craig. I just have very limited to add to that, Craig did a great job of identifying the feeds and the different components of the data lake. Ultimately, from our perspective with enterprise-wise analytics, it's leveraging all that data that is available within the data lake. The dashboards are powered by the clinical, the claims, social determinants of health, and as you probably can glean from the conversation here, IHDE is on a very bold mission. So as that data lake continues to evolve, we will be doing the same with using that data to create analytics.
Excellent. Thank you, Craig and Renee. One last question for the talk today. Heather asks, can you talk more about which social needs will be integrated with the medical data?
And this is Jaffer. I can talk a little bit about that. So in Aunt Bertha, we keep track of several domains of need. And this includes food, housing, shelter, transportation, financial needs, and there are several others. And so this touches a little bit on the topic of standards. And so there is a couple of national efforts, including the Gravity Project, where many organizations, including HHS, the ONC, many health systems are participating, including vendors, to create the standards for social care risks across the country so that this data does become even further interoperable. And so any data for any of those risks will be captured and a part of this particular partnership. How that data is codified and then shared perhaps outside of this partnership will depend on some of how the HIE uses those standards moving forward.
Thank you, Jeff.
Thanks. I would add a little bit that there are a number of different applications out there that are using both Aunt Bertha and some other tools to assess social determinants of health. And IHC is going to make an effort to both integrate with those systems that do have their own SDOH platform, and also to draw other social determinants of health data out of EMRs as we widen our connection capabilities with our providers. We're also working closely with a number of behavioral health clinics, trying to get more of those folks onboarded, addiction treatment centers, as well as homeless programs. And that's another piece that we've been working hard on, and have a couple that have joined IHDE and are going to start to integrate their data. We're also doing a full bidirectional interface with corrections. So we'll be getting both the Horizon information out of there for their electronic medical record, but their behavioral health data as well in the near future. So there's a push for us to widen the amount of social type determinant data that we can get to. We're also going to be working very closely in the near future with the Department of Health and Department of Welfare to be able to access their discrete data sets that they have available. So you'll see that over the next year, our access and availability of multimodal data will expand. Stop there.
Excellent. Great question, Heather. Thanks, Hans. And that is all the time we have for today. A big thank you on behalf of HIMSS members to IHDE and its partners. Hope you all have a great rest of your week, and we'll see you next month where we'll hear from the CIO of St. Luke's. Thanks, everyone.